Hello and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They do not represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in today's episode, we discuss sleep disorders. Sleep is a huge and incredibly disruptive problem for so many men. In fact, did you know that 70 million Americans currently have a sleep disorder? But what causes us to have sleep issues? How can we prevent them? Are any of the multitudes of supplements and over-the-counter remedies even worth trying? And when should guys consider seeking help from a doctor for their sleep issues? It turns out that the answers depend on many factors, including what type of sleep disorder is actually causing the issues. To help us sort through these questions, we turn to an expert. Dr. Sam Kashani is a sleep specialist at UCLA. After completing his residency at the Arrowhead Regional Medical Center, Dr. Kashani pursued a fellowship in sleep medicine at UCLA, where he now serves as a clinical instructor. Dr. Kashani also currently serves on the board of directors for the California Sleep Society and is a frequent lecturer on sleep issues. And now, without further ado, I bring you our conversation with Dr. Sam Kashani about managing sleep disorders. Welcome to Better Man Clinics. Today, we're going to be talking about sleep, or more importantly, sleep issues. It's a problem that most men have faced at some point in their life, but in our crazy, hectic lives and with all of the chaos that COVID has added to them, sleep has become more and more and more of a problem for a greater percentage of men. And we know that a lot of you guys out there have a lot of questions about sleep, like, am I doing anything wrong to not get enough sleep? What can I do to get more sleep? Are there medications or treatments out there? And when is it time to potentially see a doctor? We're going to answer these and many more questions because today we are very happy to be joined by a true expert in the field, Dr. Sam Kashani from UCLA. Dr. Kashani, welcome to the program.
Thank you so much for having me. I appreciate it. Happy to be here.
Thank you. We're very excited to get started and to hear your thoughts on this. And before we jump into sleep, I always like to ask our experts a little bit about themselves. And what I love to understand is what inspired you to become a doctor focusing specifically on sleep medicine?
Well, I had a very different career before medicine. I actually majored in film and television arts in undergrad, and I started working in film production and worked for Sony Pictures for a while. Then I went out on my own and I started producing independent documentaries. So I had a very sort of situation before considering medicine, but I did always want to become a doctor ever since I was young. And once I became a broke filmmaker, I decided that was probably the right time to.
that was a good challenge, right? Awesome. That's definitely a unique path. And why sleep in particular?
Well, the simple answer is that I found a lot of other specialties to be kind of boring, but in all seriousness, no, I think sleep is very exciting. It's a relatively newer specialty within medicine. It's only a few decades old. We're still learning so many things just about sleep physiology and circadian science. We have new studies and investigations happening all the time, which just makes it even more exciting. It's a very academic field, and it's very multidisciplinary in the sense that a lot of the problems that I treat as a sleep specialist are pulmonary. Many of them are neurologic. Many of them are behavioral. So ultimately, I think it kind of gives me a little bit of a hand in various different parts of medicine.
That sounds really interesting. I mean, it makes sense that it comes from so many different specialties that you bring together to solve the problem. I really like that. We really try to get away from let's just hit all the nails with one hammer, right? And really take a step back and look at the whole patient, the whole person, which is fantastic. So before we get into the actual practical elements of sleep, I'm going to ask you a basic question, and I'm sure I'm going to open Pandora's box here, but from a physiological perspective, why do we need sleep?
Yeah, so essentially the human body, we have two sleep drives, and we refer to this as the two process model. There's what's called process S and process C. Now, I don't want to get too technical with it, but essentially process S just refers to our homeostatic sleep drive. So this is what we call the sleep pressure, the feeling that you have when you go a long period of time without sleeping and you start to feel that pressure beating down on your brain, like I need to sleep, I need to sleep. So that's really of the sleep drives. Like I said, that's process S, the homeostatic sleep drive. It builds up throughout the day, the more and more we're awake, and then it kind of peaks right around the time we were ready to just hit the hay and go to sleep. And then there's C, which is our circadian sleep drive. And this is the role that our circadian rhythm and the environment plays in sort of modulating when our body should be awake and when our body feels sleepy. And it's really the combination of these two sleep drives, the circadian sleep drive and the homeostatic sleep drive, that together sort of inform our body more or less when to be tired and when we need to sleep and whatnot.
Got it. And so I guess when nobody really, I mean, I'm not going to say that, I'm sure we do know, in terms of what happens when we're sleeping. I understand there's a lot of kind of replenishment going on. And the second part to that same question is, what are the mental and physical consequences of not getting enough sleep from a physiological? I mean, we all know, I'm tired, I need to go to Starbucks, maybe I'm not thinking correctly. I know from a lay perspective what that means, but from a physiological perspective, what happens when you don't get enough sleep?
Good question. Yeah. So insufficient sleep, whether it's a result of insomnia, whether it's a result of behaviorally induced insufficient sleep and someone who self-sleep deprives, whether it's somebody who has sleep apnea, for example, a disorder that is a breathing disorder during sleep, which does deprive us of the sleep that we need because it essentially interferes with our ability to achieve the depth of sleep each night that we need. But really the consequences are really, there's just so many, I don't know where to begin. We can start with mental dysfunctional mood, which of course we can all sort of relate to that, even just with one night of partial or total sleep deprivation. We all know the way that we feel the next day. It's not really a representation of our true personality, for lack of So, worsening mood, issues with irritability, just the way that we interact socially on an everyday basis with our friends, our family, our colleagues, everything is really affected in terms of a social and a mental standpoint. And then in terms of physical, you've got naturally, of course, daytime sleepiness, fatigue, the daytime symptoms that we see with a lot of these untreated sleep disorders, insomnia, sleep apnea, and so on. Psychomotor impairment, cognitive issues with memory over time. There's an increased risk of workplace errors and accidents, car accidents. So there's really, like I said, there's just so many layers to this when you really sort of trace the trajectory of what happens as a result of chronic sleep loss and the way that it affects not only the short term on a day-to-day, but just the long term and the way that our brain works. Like I said, dementia and cognitive deficit is something that's been very, very well studied in the setting of insufficient sleep, whether it's due to insomnia or sleep apnea, for example. So these two, of course, being the most common sleep disorders that we treat as sleep specialists.
That's so eye-opening. Everyone treats sleep as, I'll overcome, I'll get an extra Starbucks, I'll be fine, I just need to power through, I need work to do. And people, I think, don't give enough credit to how important sleep is. And all of these points you brought across from a cognitive brain perspective, it's not just, because I need to stay awake the next day. It's really, there's things going on in your brain when you're sleeping that really allows you to function. And it definitely seems like in our crazy, hectic world, we don't give it enough credit. Now, that being said, let's get a barometer here, right? If I'm an average guy, how much sleep should I be getting?
Good question. So, I always tell people that rather than striving for a magic number, first of all, it's important to note that the average adult sleep duration, the average adult sleep requirement is 6 to 8 hours per night. Okay. Now, some people need 6, some people need 8, some people, of course, fall in between. But essentially, the important thing is that we're sleeping enough to the point that we feel refreshed. We're sleeping enough to the point that we don't require any more sleep. We're not curtailing the end of our sleep period like many of us do. Mm-hmm. And we're fighting daytime symptoms. That's really a really big part of all of this. I keep on going back to that just because even when we look at the diagnostic criteria of our sleep disorders like insomnia, like sleep apnea, we're always referring to the daytime symptoms and the effect that it has on the daytime. So essentially, if somebody's achieving enough sleep such that they are waking up feeling refreshed, don't require any more sleep, and have no daytime difficulties or distress associated with their quantity of sleep that they achieved, then that's what their magic number is. And everybody's individual magic number is different for that reason. Now, that being said, we do have such thing as what's called the long sleeper and the short sleeper. And yes, those are scientific terms. The long sleeper is defined as the person who requires more than the average adult. So like I said, with average adults, 6 to 8 hours of sleep duration. If somebody needs 9.5 hours, and as long as they get those 9.5 hours, they're perfectly functional during the day. They have no difficulty falling asleep, no difficulty staying asleep, no daytime symptoms whatsoever. They just need their 9.5 hours. That's your long sleep. And then the same thing applies to the short sleeper. Now, I like to talk about the short sleeper a lot because a lot of people say, well, I think I'm just one of those short sleepers where I just need 4.5 hours and I'm totally good.
Right.
Like Donald Trump, for example. So Donald
That's
Trump.
Right. He's the classic example, right?
Exactly. We call that sleep machismo. Somebody who sort of about the fact that they just require this few hours of sleep and they're totally good during the day and they're not tired at all. And you know what? I believe people like that. I believe Donald Trump when he says those things because he doesn't have time to experience daytime symptoms. He doesn't have time to feel tired. He wakes up, he's got 10,000 things on his itinerary, everything from phone calls to meetings to trips to all sorts of different responsibilities. He doesn't have time to sit down in front of the couch and watch Oprah with some popcorn in his hand, because if he did, there's a good chance he might be out within 30 seconds like a light bulb. But that being said, there are many people who, will sort of say that I'm just a short sleeper, but really what they're doing is just depriving themselves of the sleep that they require and pushing through, as you said, whether it's with the use of caffeine or even if it's just like I said, the human mind is strong. We can fight through things like that. We can think, okay, I'm so focused and go, and I've, my priorities set out for the day. I'm not even thinking about being tired. And we do get into this habit, and this kind of creates a challenge for sleep specialists because with daytime fatigue and sleepiness being one of the most primary symptoms and reasons that we assess patients and the reasons for referrals, if we're all used to being tired on a daily basis because that's just part of our norm, well then it makes it challenging. Does this person have a symptom, or have they just adapted or adjusted to feeling this way?
Right. That's what I was going to ask you. And you just answered, like, okay, how do you tell the difference, right? How do you tell the difference between the fact that you're just a short sleeper or the fact that you're making yourself a short sleeper and you're compensating for it, right? But I guess that is not an easy question to answer based on what you're saying. It takes a lot of work to kind of delve into that. But I guess it is fair to say that once you start seeing impacts on your life that, that Starbucks can't cure, or Red Bull can't cure, I think that's kind of your body really, I would imagine your body really telling you that, something's going on here. We need to get to work, right, to fix it, I would assume. Now, there's different types of sleep problems that we're going to go into. I want to start off with one of the more common ones, I guess, probably in younger, and I used to consider myself younger. I'm going to call myself early middle-aged people, and that's trouble falling asleep. Right? Like they just can't fall asleep. What are the common causes of that prevent people from just being able to fall asleep?
Yeah, good question. So difficulty falling asleep, or what we refer to as sleep onset insomnia or sleep initiation insomnia. It's when somebody has exclusively difficulty with falling asleep, it can somewhat help you sort of narrow down a couple of the causes. Now, of course, with difficulty falling asleep, the problem is happening essentially while the person is awake.
Right.
So it's very keep that in mind, that while they are awake, first of all, what are they doing? Is this a behavioral issue? Are they, engaging in, or for example, looking at electronic devices? Are they, like I said, self-sleep depriving? Is this a behaviorally induced insufficient sleep pattern where they're just staying up late and looking at things and in bed while watching TV and whatnot? So that's keeping it very simple, sort of just looking at the sleep hygiene, the sleep environment, and the behavioral issues that may make it difficult to fall asleep. But other things that can make people have difficulty falling asleep very commonly is mental health issues. So for example, anxiety, a very, very common thing that keeps people up at nighttime. It could be generalized anxiety and people who just have anxiety about various things throughout the daytime, including their sleep, because of course we all want to make sure that we get enough sleep for the following day. Or it could be sleep-related anxiety, which as a sleep specialist, I see all the time. Because, for example, if we get into a habit where our sleep is a little bit broken, or we're experiencing a brief transient sleep disturbance or a difficulty with insomnia for whatever reason, it could be just some precipitating factor, like we just moved to a new house, or we, just got a new job, or some sort of a change that sort of precipitates a little bit of a sleep difficulty. Very commonly happens to all of us and usually self-resolves. But if the person gets into this habit where they start to develop bedtime anxiety, or they start to think, okay, well, here's, I've had a bad week. Gosh, I hope I have a good night tonight. they start to sort of develop these perpetual thoughts, these dysfunctional thoughts about sleep and not getting enough sleep and the detriment that might have on the following day. And next thing you know, that just perpetuates more and more insomnia, because we're essentially taking these dysfunctional thought patterns and sleep-related cognitions into bed with us every single night, pairing them with that environment, sort of the way that Pavlov paired, the sound of the bell with the smell of dog food. It really comes down to sort of conditioning of stimuli. And that's why a lot of the behavioral treatments for insomnia that we use, which we'll talk about later, are geared towards exactly sort of changing and disrupting these patterns and associations, because ultimately it's us very often that sort of get in the way of us being able to fall asleep at night, whether it's from dysfunctional sleep-related thoughts, generalized anxiety, like I said, and then of course, moving away from mental health. There are other physical issues or physiologic issues that can preclude or affect somebody's ability to fall asleep. Restless leg syndrome is a very, very common example of one. Restless leg syndrome is something that happens when we're still awake. It's an uncomfortable feeling of the leg. It makes you feel like you need to move your leg in order to get it comfortable. And then when you move it, it gets a little better for a few seconds. But then some people, they kind of have a very constant feeling where for the next hour or 2 hours, they're constantly having to move their legs, stretch it out, massage it, walk around. Next thing you know, 2 hours goes by, they can't fall asleep. Well, that's sleep onset insomnia secondary to a restless leg. And of course, treating the restless leg in that situation will improve the insomnia. So these are some of the things that stop people from falling asleep.
Got it. So I want to go back to one of the things that you mentioned at the very beginning of this, which is technology. That I know that comes up a lot, particularly with children, in terms of being able to fall asleep. So multi-part question with technology. First question is, why does technology prevent us from falling asleep? And second question is, what if I was in your practice and say hypothetically I'm a little technology obsessed, definitely not me, but let's say it was, what suggestions would you give me to, if you thought that technology was playing a big role in my inability to fall asleep?
I always tell people that devices, they have a twofold damage or a twofold detriment. Number one, naturally, whatever you're looking at on these devices is stimulating content. It's engaging. It's something that you're interested in. It's something that you're somewhat actively listening to or looking at. So you're essentially kind of keeping your brain active and sort of working at a time where you want to sort of wind down and get yourself in and get ready for sleep. So that's one way. It's just the pure stimulation that comes from these electronic devices, whether it's the phone, tablet, or the TV. And then there's the effect of bright light. So this goes to circadian rhythm now. So our body's circadian rhythm, which is essentially the clock that works around the 24-hour period, letting our body know when to regularly feel sleepy and when to regularly feel alert, is modulated heavily by certain zeitgebers or environmental cues. The number one environmental cue that modulates our body's circadian rhythm is bright light exposure. So bright light exposure. You may have heard, or you may see people who use a white light box, for example, or even physicians, psychiatrists who recommend the use of a white light box to help with mood, to help with seasonal affective disorder in places where they don't necessarily get enough bright light, like in Scandinavian countries or Alaska or other places like that. But really, it's important to know that the effect of bright light on our sleep-wake pattern and our circadian rhythm is such that when we expose ourselves to bright light first thing upon awakening in the morning, it has the tendency or the ability to advance our sleep-wake pattern. So essentially keeping our sleep-wake pattern and our circadian rhythm sort of regular and intact so that we feel sleepy early on like we should be, or we feel tired early on like we should be. So by the time we make it to bed, we go to sleep. However, exposing ourselves to bright light too close to bedtime, which is what we're doing essentially when we're watching TV in bed or looking at our devices in bed and whatnot, that has the opposite effect. That can actually delay our circadian rhythm because it essentially will delay the brain's secretion of melatonin and the sleepy hormones that help us go to sleep at nighttime. This gets delayed the more and more we expose ourselves to bright light at nighttime. And this is why you have teenagers with what's called a delayed sleep-wake phase syndrome. Delayed sleep-wake phase syndrome is a circadian rhythm disorder, which is a mouthful of a name, but essentially refers to somebody who is sleeping late and waking up late. And most commonly affected by this, I most certainly was one of them, where we get into the habit of staying up later and later and later, plus we're looking at devices, plus we're looking at TV, plus you have these age-related changes in the brain that all sort of sum up together. Next thing you know, you have a 17-year-old who can't fall asleep before 5 a.m. and is struggling all throughout the week, falling asleep in class. People are wondering, does this kid have narcolepsy or something like that? But no, it's just because he slept 3 hours last night. Now, of course, fast forward to Saturday or Sunday, you can't get him out of bed before 2 p.m. in the afternoon. So that is classic delayed circadian phase or delayed sleep-wake pattern, and predominantly a result of bright light exposure close to bedtime. So I really kind of break it down to those two things. Like I said, stimulation from the content of the device and the ability of the electronic or the bright light exposure from the device to delay the circadian sleep-wake pattern.
Well, that's actually very helpful. Just I'm going to ask a follow-up question, but it's interesting because especially for teenagers who aren't the biggest audience of this podcast, but nonetheless, the always thought is, well, they just need more sleep. So they're just going to, the bottom line is they have to sleep till noon because they have to sleep till noon because they just need to get those extra hours. But I don't know how much we're taking into effect the fact that they probably didn't go to bed till 2 a.m. And that's probably why they need to sleep. It's not just the fact that they need to sleep for 16 hours a day. At least that's the perception that they do, basically. With respect to that, understanding that, listen, technology, screens, whether it be TV screens or iPads or phones, are detrimental. When should be the cutoff time? How soon or how far ahead of going to sleep should you shut things off?
I tell people, first of all, I'm a realist. I tell people, I don't expect you to not answer your phone after 8 p.m. or something like that. So I always tell people just in that last hour or two.
There you go.
Sorry.
No problem.
In the last hour and a half or so before you go to bed, really sort of adopt a nice wind down pre-bedtime routine where you're not necessarily just shutting everything down. If you can, great. The more you can eliminate, the better. But if not, just trying to keep the environment sort of calmer in a sense of lights, not only from the devices, but even just from your lamps, from your lights at home, keeping everything dim, keeping everything on the more quiet side. And then in terms of your devices, of course, the good thing these days is a lot of the mobile devices have the night shift feature where it sort of reduces the intensity of the blue light. Now, it's important to know that the night shift feature doesn't mean that all the blue light has been knocked out of the device and you're totally protected. Right. Either. It reduces it though, which every little bit helps, turning down the brightness, using the night shift feature, and just overall the home environment and the bedroom environment just calmer, more quiet, more dim for that last 1 to 1.5 hours before going to bed is what I typically recommend.
Got it. No, that makes sense. It's a good habit to get into for sure. And I'm just going to jump back and forth a little bit with regards to that. So you had mentioned dimming things, quiet. Any other pre-sleep habits, like in terms of the environment? I've heard about temperature and stuff like that. Anything else? Like, how do we optimize that pre-sleep situation aside from cutting down the devices, I guess?
Absolutely. So now we're getting into sleep hygiene. So sleep hygiene just refers to exactly what you just asked me, sort of ways to optimize the pre-bedtime routine as well as optimize the bedroom environment to make it as conducive and sleep promoting as possible. So other things that we recommend include, I'm a huge pusher of this, no clock watching. Clock is one of the worst things you could do at nighttime when you have insomnia, of course. If you're a perfectly good sleeper and looking at the clock doesn't do anything to you, then no worries. But if you have insomnia, like many people do, and like many people with insomnia and many people who have experienced insomnia in the past may relate to, looking at the clock is very stressful because another hour goes by. It's, oh my God, here's 3 o'clock in the morning. I've only been asleep for an hour. How the heck am I going to function today? I can't function on less than 5 hours of sleep. Yesterday was terrible. Today is going to be terrible. And again, that sort of pattern, that perpetual sort of cycle of dysfunctional sleep-related cognitions and thoughts that we develop again, night after night, again, perpetuating the problem. So I always tell people, turn your bedroom into a Las Vegas casino.
Okay.
When you're get slot machines and everything. No, I'm just joking.
Right. That's a good plan. I like it.
When you're sitting in a Las Vegas casino, you have no idea what time it is. Right. There are no clocks within sight to let you know what time it is, nor are there any windows to really let you know what time of day it is outside. And of course, that's how they get your money, because you're sitting there for hours and hours and you have no concept of time. That's how the bed should be. There's no need to look at the time. All you need to know is that your alarm clock is set for the time that you need to awaken. Otherwise, any sort of environmental cue as to what time it is just augments frustration, more stress, more distress, more, oh no, I'm not asleep yet. I tell people blackout curtains, very important, just because, of course, when that little blue tinge of light blue comes out at 5:30 in the morning, immediately you start thinking, oh boy, it's already 5-ish. Should I just get out of bed already and start the day since I'm up? Or should I try another 30 minutes of sleep? Here we go again, tossing and turning, and then that perpetual cycle continues. So black curtains, windows closed, because of course, if the street sweeper comes at 3 o'clock in the morning every time and you can hear it perfectly and you know that it comes at 3 o'clock in the morning, well, then that's going to tell you what time it is as soon as you hear it. So closing the window, blackout curtains, no clocks or time visibility whatsoever. And then in addition to that, you hit on it earlier, keeping the room cool, dark, quiet. So cool, we define as, there's really no perfect temperature. We say cool enough to be comfortable so that you're not freezing uncomfortably. But the American Academy of Sleep Medicine has actually suggested between 65 to 70 degrees Fahrenheit for the bedroom environment.
That's pretty chilly. Yeah. That makes a lot of sense. Now, what we talked a little bit about the pre-sleep habits. We talked about lifestyle, right? The stress, all that kind of stuff. What about diet? What role does that play in terms, or does it in terms of people having trouble sleeping or falling asleep?
When it comes to diet, I tell people to just, first of all, keep a couple of basics in mind. Number one, don't go to bed too hungry. Don't go to bed too full. If you're hungry and you're getting to bed just, at 9 o'clock at night or whatnot, and let's say you're having a hard time falling asleep, well, frustration, next thing you know, an hour goes by, you might even get hungrier. So going on a full stomach would be a better idea. Now, of course, you don't want to be too full, because if you eat something and then lay down right after that, that can aggravate symptoms of acid reflux and make it that much more uncomfortable for you as well. So real basic, like I said, don't go to bed too hungry, don't go to bed too full. Now, in terms of the content of your diet, naturally, anything alerting or activating, you want to sort of minimize it at nighttime or in the evening. Things that have too much sugar in them, even things like alcohol, which of course is very sedating. Alcohol has other detriments on your sleep, which we'll talk about a little bit later. But essentially, just sort of really kind of, like I said, keeping it simple, avoiding things that are a little bit too activating, too sugary, too sweet, and really making sure we're going to bed not too hungry, not too full.
Now, with things like, okay, so I'm in Starbucks all day, trying to stay awake. And then once you get to that, when should you stop caffeinated beverages before, or is there a time before going to sleep where you can let them kind of wear off and allow you to fall asleep?
It's a really good question. This is one of those questions that I find it to be very, very individualized. I have people who will drink coffee well into the evening and have no difficulty with sleep whatsoever. Right. And then I have, as long as they just have that one cup of coffee in the morning, they're fine. But the moment they have a second cup of coffee at noon, next thing you know, they can't fall asleep the following night or later that night. So I find every response and sensitivity to caffeine varies. So I think it's important, when it comes to things like this, to really pay attention to your body and sort of see how you feel, and maybe experiment, move things around, move your coffee a little bit earlier, cut out the evening coffee, and see if these things make a difference, because very often they do.
Got it. And so since you mentioned alcohol recently, as you mentioned, a lot of people, a lot of my friends, myself included, say, oh, alcohol can be relaxing. You have a glass of wine, it relaxes you. All things would point to it helping you sleep. But it seems to be that there seems to be some controversy with that, or maybe not even controversy. Maybe there's some paradoxical effects potentially.
So yeah, the effect of alcohol in sleep, I always tell people, again, the detriment is twofold. Number one, alcohol affects the way that you breathe while you are asleep. So how so? Just like sleep apnea. So the whole problem of obstructive sleep apnea is that the air pipe, the pipe in your neck, the upper airway, becomes very, very narrow when you're asleep, to the point that it gets so narrow throughout the nighttime and it intermittently collapses, resulting in drops in oxygen and all kinds of disturbance to the cardiovascular system as a result of stress and inflammatory cytokines. Anyway, whole thing over there. But putting that aside, the effect of alcohol on breathing is very similar, in a sense that it narrows the upper airway, just like sleep apnea does. And this is why your friends snore so much more loudly on nights that they get hammered, because essentially it is aiding that sort of, or mimicking that narrowing of the upper airway space. So that's number one. Even to the point that somebody who does not have sleep apnea, if they drink tons and tons of alcohol on that night, they can even have what are called de novo apneas, meaning that on the night that they drink, it's as if they have sleep apnea, because they actually have drops in their oxygen as a result of breathing pauses from that airway collapse. So that's one way in which alcohol affects sleep, is that it basically narrows your airway and mimics sleep apnea. Now, in terms on your brain, so we have 4 stages of sleep: non-REM 1, non-REM 2, non-REM 3, and REM. REM is rapid eye movement sleep. That is a very deep and unique stage of sleep, during which the body does a lot of its sort of restorative processes and taking out the trash, as we say. But one thing about alcohol, like many other substances, but alcohol in particular, very potent in this regard, is that alcohol is a potent REM sleep suppressant. So essentially, in the presence of alcohol, the brain is actually unable to achieve the depth of REM sleep that it requires each night. Now, keeping in mind that alcohol has a metabolism of about 4 to 5 hours before it really starts to break down into its metabolites, well, that essentially means that for the first half of the night, or for the first half of the sleep period, we practically get no REM sleep. So the brain is essentially trying to go from light to intermediate to deep, but it's getting stuck up here and it can't really get down there. And then next thing you know, alcohol breaks down into its metabolites in that second half of the night, and we get what's called a REM rebound, where essentially that REM that we were suppressing or that we were deprived of for the first half of the night begins to sort of rush into the brain in those last few hours. And that's just not the way the brain likes to do it. The brain doesn't want to achieve the depth of sleep in that way. It wants to do it in a sort of cycling kind of way, where you're going from light, intermediate to deep, and sort of just cycling all night, rather than just being in light intermediate all night in the first half and then dropping into deep suddenly. And this is why very often you'll hear people talk about how the quality of sleep on alcohol is just not very refreshing, and it's not very restorative, essentially because it's really sort of distorting your sleep staging and distorting your sleep architecture. So.
Got it. Well, that makes a lot of sense. So basically, if I can just summarize it, I mean, basically what you're saying is that while, your buddy who got drunk is snoring like a sailor next to you, maybe, and, compressing his windpipe, as you said, and he looks like he's having the best sleep ever, in reality, the sleep he's having is not particularly efficient. He's not restoring himself. So the next day, as we know, after that, he's not exactly going to be bright and perky, quite the opposite, because even though he was passed out, he's not really getting efficient sleep. Does that sound about right?
That sounds exactly correct.
Perfect. And, just since we were talking about, I'm going to go back and ask one other question, just in terms of risk factors, medications. People are on a lot of prescription medications that they need to take. It's not recreational, but they are. Are there any that people should be aware of, specifically if they're having trouble falling asleep, that we should be aware of?
Yeah, absolutely. Well, naturally, certain stimulant medications, medications that we often actually prescribe as sleep doctors to patients who have disorders of hypersomnolence or disorders of excessive sleepiness, like, for example, narcolepsy. We treat disorders of excessive sleepiness very often with wake-promoting agents or stimulant medications. These are things that essentially keep you up and alert during the day and make it easier to maintain wakefulness so you're not fighting sleepiness. So medications like that, which are prescribed for a number of disorders, not just narcolepsy and disorders of hypersomnolence, but many people are on these medications for things like ADHD. Many people take these medications for shift work. And these are very common, very, very common causes of difficulty with sleep at nighttime, because, of course, once again, everybody's body is different. Everybody's sensitivity and response to these different medications and substances is different. So even if you take these medications early in the day, it can potentially cause difficulties with sleep at night. So that's one thing to keep in mind. And of course, there are certain antidepressants, actually, which are more alerting and activating versus other antidepressants, which are a little bit more sedating. So the timing of these medications is very important as well. Medications that are alerting, naturally, you would want to probably take those earlier in the day as opposed to at nighttime. Several, like I said, antidepressants, including Prozac, can have that effect. So it really sort of just depends on what the indication for the medication is, but these are some of the more common medications that can make it difficult to sleep at night. Beta blockers, for example, another class of medications that we use to treat certain cardiac conditions, high blood pressure, various other uses of these medications. These medications, being that very many of them are centrally acting and cross the blood-brain barrier, they can also make it difficult to sleep at nighttime as well. So kind of hard to really isolate. I find that in general, when you're treating insomnia, chronic insomnia, isolating factors like medications, substances, these are all very, very important. But what happens a lot in insomnia is that regardless of these other factors is, once again, the person sort of after a while develops these dysfunctional sleep-related cognitions and these sort of maladaptive behaviors to try to help themselves sleep at night, like taking Benadryls or alcohol or whatever the case may be. It's really these things that further perpetuate the insomnia, because once the insomnia sits in, like I said, it starts to really affect this here and sort of kind of take it from there in terms of perpetuating the cycle further.
No, that's really helpful, because, a lot of guys, they get prescribed a medication and they don't put two and two together when all of a sudden they start getting sleep problems, because then they start attributing to, I'm having a tough time at work, I'm arguing with my partner, you name it, right? And they don't put two and two together. And while we would hope that the physicians or practitioners prescribing that medication would ask a follow-up always, like, how's your sleep going? And you're having problems with sleep, they may not always think to. And so it's important for guys that are getting prescribed new medicines, particularly antidepressants, anti-anxiety, but even, as you mentioned, the beta blockers, like even blood pressure medicine, keep that in mind. And, public service announcement here from Better Man Clinics: don't stop medications without your doctor's approval, but definitely talk to your doctor about it and let them know that you're having those problems and see if indeed they're related. Now, Dr. Kashani, I want to play a game with you now. It's called Real or Not Real. There's a lot of stuff out there that's sold in the supermarket, online, on on TV, that will be your sleep cure, and it's all natural, and it's at a very low price. And some of it, I understand, supposed to help a little bit. Some of it might help a lot, and some of it may not be much of anything. So I want to throw some of these out here and just get your thoughts about real or not real. The first one, which is probably the one I hear the most, is melatonin. What are your thoughts on that?
I think melatonin has no evidence as a sleep aid.
Wow. So we're going to say not real.
Now, that being said, again, when it comes to sleep, like many other things in the human body, the individual response is important to keep in mind, because plenty of people out there will tell you about how melatonin saved their life and how just taking melatonin at nighttime is all they need to help them sleep. I tell those people, great, no problem, keep with it. It's working for you. You're tolerating, you're not having any bad side effects. There's no problems. Wonderful. But if somebody comes to me and says, I'm having insomnia, do you recommend I start melatonin? Well, as a physician, my job is to recommend evidence-based treatments. And since melatonin does not have evidence, of course, I can't recommend it. I can always tell you to try it and consider trying it and go, try one over the counter and see what happens. But is it going to be an evidence-based recommendation? Is that my solution that I have to offer you as your doctor? Not really, no. I have better things, or not better things, but things that have stronger evidence. Doesn't necessarily mean that they're better. They just have more evidence. So melatonin just so happens to be one of those things where in sleep medicine, we actually do have a couple of evidence-based uses for melatonin, but they are not insomnia. One of them is for circadian rhythm disorders, where melatonin can actually work to shift somebody's circadian pattern into a different direction, whether advancing their sleep-wake clock or delaying it. And also, another situation in which we use melatonin is for the treatment of something called REM sleep behavior disorder, which is one of my areas of specialty that I like a lot, that I'm strong interest in and done research in, which is a sleep disorder where it's very common in older men, actually above the age of 50. And essentially it's characterized by people who act out their dreams at nighttime, dream enactment behavior, as we refer to it. Usually these are people who are seeing nightmares. The dreams often are about fights, altercations, conflicts, chases. And next thing you know, the person in bed is actually exhibiting movements that correlate with what they're seeing in their dream, whether it's punching, kicking, running, or even getting out of bed. I don't know if you're familiar with the comedian Mike Birbiglia, but he has this, actually. He has REM sleep disorder, and he talks about it in his comedy sketches all the time and shares stories about how, for example, one time he was in a hotel room and was having a nightmare and physically got up out of bed, and I believe he jumped out of the window, if I'm not mistaken.
Oh my God.
So, in any case, back to your original question, melatonin. Melatonin.
No, this is great. Keep going.
In this particular setting, in people who have REM sleep behavior disorder, who act out their dreams, melatonin has a very unique property that it can actually augment the brain's ability to paralyze the skeletal muscles during sleep, or during REM sleep specifically, because REM sleep is when we have most of our dreams. And REM sleep is also very unique in a sense that our skeletal muscles are paralyzed exclusively during REM sleep, not the other stages of sleep. However, if that skeletal muscle paralysis, if that sort of mechanism for the brain to paralyze the muscles is not working well, or it's dysfunctional, well, then what do you have? You have somebody who literally is going to start acting their dreams out. And that's where melatonin can be effective. It can help sort of augment that brain's capability to paralyze the muscles. So these are really the only two uses that have evidence, that the melatonin has evidence and sort of can work for, is, like I said, shifting someone's circadian rhythm or treating dream enactment behavior in the setting of REM sleep behavior disorder. Outside of that, including insomnia, melatonin has no evidence to suggest any other sleep-related benefit.
Not to dive into those weeds, but I'm just really curious. Is it the fact that there's no evidence, meaning there haven't been enough studies done, or the studies just haven't shown a significant benefit from melatonin?
Both. That's an excellent question. Both of those are the correct answers.
Got it. Got it. Let's go on to the next one then. What about magnesium supplements?
Same thing, no evidence to suggest that magnesium can be an effective treatment for insomnia. Now, many people, just like melatonin, do experience some benefit when they take magnesium at nighttime. A lot of my patients have told me that they feel more relaxed. Plus, one other way in which it may help is people who experience what are called nocturnal leg cramps, which are essentially leg cramps that sometimes can make it difficult to fall asleep as well. Sometimes some people experience benefit with nocturnal leg cramps with the use of magnesium. So it's definitely something that can help some people, like I said, but again, major lack of evidence and not something that we would typically recommend from an evidence-based standpoint for the treatment of insomnia.
Got it. Now, another one I came up on online that actually my mother from her roots in Russia would promote for calming people down, like for whatever reason, not necessarily for sleep, is Valerian Root. This was her go-to from a Russian medical cabinet. What are your thoughts in terms of Valerian Root specifically for insomnia?
Not to sound like a broken record, but very similar. Very similar to what I've been saying, in the sense that no evidence. Plenty of people will tell you how they benefit from it. I've even actually met other sleep doctors who like to use it. Actually, it's like I said, it's one of those things where I'll say, hey, feel free to try it. I'm not telling you that it's necessarily going to work, but I think when it comes down to really all of these things, all of these supplements and over-the-counter solutions that people try to reach for to help them sleep, ultimately, if it helps you, great. But my favorite thing is when people come to me and say, I've tried everything already. I've tried magnesium, I've tried melatonin, I've tried valerian root, nothing helps. Something is wrong with me. And I say, there's nothing wrong with you. You tried a bunch of treatments that have absolutely no evidence. The fact that it didn't work for you is not abnormal at all. In fact, if you had come to me saying that you tried something that actually had evidence and it didn't work, then I would say, okay, well, let's figure this out. But there's nothing wrong with it. Just tried non-evidence-based treatments that help, a certain subset of people and not the majority, and that's it.
Got it. So I'm going to throw out one more. I have a feeling I know what you're going to say about this, but this is one that it gets cred for everything from back pain to congestive heart failure, is CBD oils. What do we feel about CBD oils with insomnia?
So when it comes to cannabis and sleep, so this is an area of growing research. Cannabis products, even looking at THC, looking at CBD. There's even been studies looking at THC with regard not to the treatment of only insomnia, but even with the treatment of sleep apnea, which is kind of strange. Like, how could something like THC or a cannabis product improve somebody's breathing? But there was a very small study that showed some interesting results. Anyway, bottom line is, we barely have any evidence here. I mean, the research is really lacking in this area. We really need it because, of course, this is something that we're learning more and more about, the benefits of cannabis with regard to a multitude of other medical issues. So I think that when it comes to sleep, that's definitely something that we need to sort of stay tuned for and sort of see what comes out of that research. But as of right now, we don't really have any evidence, to say what effects it specifically has on sleep or what improvements or benefits somebody may experience with these products. But again, many people take these things and it does help them. So we'll have to see.
Based on that, actually, so most of these, I'm not sure about CBD oil, but most of these are available kind of over the counter, supermarkets, CVS, whatever. You had mentioned that you don't have a problem with patients trying it, or even before they come to see a doctor, it can't hurt. Are there any precautions to be considered of, like, if you're just a guy off the street, anything you should be thinking about with these particular supplements, any particular categories of people that need to be worried about, any kind of general precautions, because these are completely unregulated. So I'm just curious in terms of, is it as safe as just taking, a vitamin C supplement, or is there something we should be thinking about when we take this as a trial, let's say?
It's a really good question. And you hit it on the head a moment ago when you said that these things are poorly regulated. Even one bottle of melatonin from another, you don't necessarily know what you're getting. So good question. I say that the way to play it safe and the best way to do it is to just speak with your doctor. And in terms of, because everybody's sleep difficulty is different. A lot of over-the-counter products, whether it's melatonin, valerian, they sort of have this kind of promise that all sleep issues will resolve with this. You'll just sleep. But sleep issues are very specific, like you said, whether it's a sleep onset problem in the beginning of the night, whether it's a sleep maintenance problem and the person has a lot of awakenings, don't necessarily have a hard time falling asleep, but they can't stay asleep, or people who have neither and just wake up too early morning awakening insomnia, as we call it. So I think that it's really important to keep in mind that sleep issues should not be treated with a sort of uniform kind of one size fits all approach. And that's why the safest thing is really to just see your doctor, determine if it's in your best, and determine if it's most appropriate for you to see a sleep specialist. And that person can not only work with you to kind of, counsel you on all the different supplements and evidence-based and non-evidence-based treatments that are out there, but also really sort of counsel you and give you really important things and really important advice that all of us need, like good sleep habits, like good sleep hygiene, and other behavioral changes and treatments that actually have stronger evidence than medications. Ultimately, when it comes to treating insomnia, we've been talking about medications right now and supplements and whatnot, but the evidence shows that even the strongest sleeping pills that do have evidence showing that they're effective for the treatment of insomnia are still not as effective as behavioral treatments for insomnia.
Mm-hmm.
So the most effective treatment for insomnia in adults, and this is whether it's short-term or chronic insomnia, is what's called cognitive behavioral therapy for insomnia.
Mm-hmm.
There is no more effective treatment for insomnia in adults than CBTI. And that's been compared head to head with sleeping pills like Ambien, like Lunesta, prescription strong sleeping pills, and still show more benefit. Why? Because sleeping pills really what they do is put a Band-Aid, and Band-Aids can sometimes be very effective. And I'm not trying to say that sleeping pills are the devil. Plenty of people do. Every human body and human brain is different. Plenty of people take sleeping pills long term and do just fine on them and don't have side effects and feel okay. But again, it's not the most effective treatment because essentially it's putting a Band-Aid on a continuously bleeding wound. And that's where cognitive behavioral therapy for insomnia comes in, because CBTI really gets to the root of that bleed. It really addresses a lot of those cognitive and behavioral issues that perpetuate the insomnia, like we were saying, those dysfunctional sleep-related thought patterns and cognitions that we develop, those maladaptive sleep behaviors that we develop, whether it's reaching for substances, reaching for supplements, using our bed for things other than sleep. These are all considered maladaptive sleep behaviors. This is where cognitive behavioral therapy for insomnia is the most effective. It really undoes a lot of these things. It changes your behavior, and it changes the way that you perceive sleep, because that's what gets altered when you have insomnia for a while. The way you look at your bedroom. A lot of people with chronic insomnia hate their bedroom. You take them out of their bed, put them in a hotel room for a night, and they sleep much, much better, because the degree of conditioning with that environment at home has become so strong, and that enhancement of distress and no sleep and their bed has become so strong that it's almost, like I said, it's become what we call a conditioned arousal or a conditioned insomnia. So with that being the case, that's why cognitive behavioral therapy for insomnia works better than all of these things. And in general, behavioral and cognitive strategies just have much stronger evidence than sleeping pills.
Yeah, I think most people, they want the easy fix that they can pop a pill and everything goes away. But based on everything we've discussed so far, especially this recurring theme of this vicious cycle, right? This vicious cycle and the self-fulfilling prophecy, which can be very hard to jump out of, because you become conditioned to that, and so this cognitive behavioral therapy, it makes sense what you're saying, because it sounds like what you're doing as a doctor in doing this cognitive behavioral therapy is that you're deconstructing all of these issues that have thus far created this vicious cycle, and that takes time. It takes effort and thought, and it's not as easy as take these and let me know how you're sleeping, right?
Absolutely, well said.
So I'm assuming, I want to just for the sake of being complete, I'm not even going to dive into the hardcore sleep pills, but just, we talked about the light and fluffies like the supplements, but there's also one thing that I definitely want to get your thoughts on, which are the little bit stronger medication that is over the counter. We're talking about Benadryl, Z-Quils, Unisoms. Where do they fit into the insomnia picture, or in your mind as a sleep specialist, should they fit in at all?
In my opinion, I don't think that they fit at all. Mm-hmm. I think that if you're able to get away with something like melatonin or valerian and everything's going well and there's no issues, then fine. But I think that Benadryl and Z-Quil and things like that, some of those things are not as benign as those other things. And for example, Benadryl, something that is a known anticholinergic, has an effect to sort of, dry somebody out. It can cause an older person to retain urine, somebody who already has difficulty with urination, for example, or bladder issues for whatever the cause may be. So now you're talking about things that actually potentially may cause problems. So I don't believe that those things have a place. Again, this is purely my opinion and my practice. I don't believe those things have a place at all. I think when you're reaching for those, you're overdue to see a sleep specialist.
And do you feel, or has the literature shown that if you start using those regularly, you become dependent on them for sleep? Has that been shown at all?
Good question. We don't necessarily have literature on that specifically. However, I think just in clinical practice, we can all attest to the fact that in general, things that help us sleep at nighttime, supplements, medications, whatever the case may be, can most certainly lead to dependence. And that's where, again, this kind of goes back to the conversation of maladaptive sleep behaviors. The insomnia is sort of causing somebody to reach for these other alternatives or other things that could potentially help them. But next thing you know, you're getting cycle of strictly depending on whatever that substance or whatever that supplement or whatever that medication is. And like I said, if it's something that you're tolerating and you're doing well on it and everything is going great, you're not requiring and doubling the dose after a few months because now you're developing tolerance, as we do with pretty much everything. If none of these things are happening, which of course, this is a perfect world. If none of these things are happening and everything is going great for years and years and years, then sure, doesn't sound like there's no need for immediate concern in that situation. But ultimately, we know that a lot of these things do lead to dependence and do lead to tolerance, requiring increased dosage. Next thing you know, you're doubling up, tripling up, and now you're exceeding the maximum dose that's recommended for these things. So again, it becomes a hard road to, once you start traveling down that road, it becomes hard to sort of go backward at that point. And rather than even going down that road, why not just sit down with a sleep specialist and get all your evidence-based and non-evidence-based options and questions answered so you can really make the best decision for yourself?
Got it. Yeah. So I think that was going to be a question later, but I guess that it seems an obvious, right? If you're starting to depend on medication to sleep all the time, that's definitely a time to see a doctor and see a sleep specialist for sure. Now we talked a lot about falling asleep. What about, some of us, we fall asleep just fine, but then we're waking up throughout the middle of the night and we're having trouble maintaining our sleep. And I think you had mentioned this as a sleep maintenance disorder. What could be causing those, and what can we do about it?
Good question. So with sleep maintenance insomnia, now, of course, we've opened up a whole new can of worms because now you're introducing sleep-related pathology that could be responsible for these awakenings and fragmentation of the nighttime sleep. So looking at sleep-related or physiologic problems, sleep apnea, once again, a perfect example of something that can break the sleep or cause somebody to awaken. People think that, because on TV, sleep apnea is always sort of the picture that's painted is this large man who's falling asleep behind his desk. Right, exactly. They're using a giant Darth Vader mask to sleep at night. But really, sleep apnea is a lot more mysterious of a condition than people think, because first of all, the signs and symptoms of sleep apnea can be very variable from person to person. There are people who have sleep apnea who do not snore. One of the more common signs of sleep apnea. Really? There are people who have sleep apnea who don't feel sleepy during the day, because once again, sleepiness and daytime fatigue is completely based on someone's perception. That is not a reliable symptom. There is no parameter to really measure that. Even our sleepiness questionnaires that we use are really sort of just very man-made and not really a very good tool at all for that matter. But essentially, it's hard to assess fatigue when, again, like I said, many people are just used to being tired all day because of course I'm tired, I'm a lawyer. Of course I'm tired, I'm an engineer. Of course I'm tired, I have kids. So the signs and symptoms, again, are very hard to assess, number one. Number two, they don't correlate with the disease, with the severity of the disease, meaning that I have patients who have severe sleep apnea who don't feel tired at all. Then I have patients with extremely mild sleep apnea who are exhausted and wake up 10. So again, very hard to assess based on signs and symptoms. So very often people with sleep apnea will just awaken and just have a hard time maintaining sleep. They'll awaken, back to sleep, awaken, back to sleep, awaken, back to sleep. So that's one example of something that can cause a lot of fragmentation or awakenings. But the question that Sorry, go ahead.
Can I interrupt you for one quick second? Just to give you had talked about sleep apnea a little bit earlier, and you had mentioned, listen, the windpipe, it kind of gets closed off. You're not getting oxygen in. The mechanism that is waking people up, is it the fact that like your body is kind of reacting to the fact that there's just no air coming in, and it's kind of like a flight or flight, like, oh my God, I'm choking kind of thing. And that's what startles you out of sleep, basically. Is that correct?
That's exactly correct. That is exactly what's happening, because in those few moments before the person actually awakens, the oxygen level has dropped significantly. The brain has gotten wind of this and said, oh no, we have an emergency. Activate the emergency response. Next thing you know, the blood pressure rises, the heart starts to get stressed out. You have what's called arousal, like I said, which is just basically a term that we use to describe an electroencephalographic disturbance to the sleep during one of these episodes. So absolutely, they awaken very often feeling startled. They awaken very often feeling like they weren't breathing well, or they just awaken, because we don't know what's going on at 3 or 4 o'clock in the morning when we're in and out of sleep. That's not a reliable time to actually get history. So to answer your question, you said it perfectly. It is the fight or flight response, that sympathetic surge that occurs in the body as a result of that emergency of oxygen dropping.
Now, I'm gonna kind of flip the script a little bit in the sense that, yes, if I'm having trouble sleeping at night, I might go to the doctor. They may diagnose sleep apnea in me. Great. But you said some people, they're not necessarily bothered by it, right? And then maybe they don't even realize they have it. But I know that there have been studies from sleep apnea like that are related to so many different disease conditions, right? So many problems that just go silent. Are there any, what are the telltale, if there are any, signs that to a guy that they may have sleep apnea that would tell them, aside from the trouble sleeping, that or maybe in addition to that, would say, you know what, maybe I have sleep apnea, I should get checked out either way. Can you share some of those with us?
Absolutely. So first of all, being a male above 50 is right there. Those are two individual risk factors for sleep apnea, being male and being above 50. Mm-hmm. Now, that's ignoring and putting aside any subjective sleep-related complaints, or, the person saying I have difficulty sleeping or whatever their history may be. Just based on their gender and age alone, you're talking they had risk factors for sleep apnea. Now, add on top of that other common issues that should alert a person to be screened or checked for sleep apnea. Snoring, like I said, even though not all people with sleep apnea snore, those that do snore and happen to be male above 50, well, now you're talking about 3 different things that suggest the possibility of sleep apnea. So snoring is definitely one of them. The daytime symptoms, once again, tiredness, sleepiness, even though they're very hard to assess. We do use a tool called the Epworth Sleepiness Scale Questionnaire, which is essentially, basically, it is naming 8 everyday, relatively ordinary, relatively sedentary situations and trying to assess the person's likelihood of feeling sleepy or potentially dozing off during those situations. Some of them include while sitting and reading, while watching TV, right after a big delicious lunch and you're sitting on the couch, whether you're in a long car ride, riding as a passenger and not having any breaks or stops on the road. So just really sort of assessing what the likelihood is the person may doze off during these very sedentary, inactive situations that Donald Trump is usually not probably in. But right. Anyway, so these are things, again, daytime symptoms, snoring, like you said, disrupted nighttime sleep or having difficulties with sleep, staying asleep at nighttime or having awakenings throughout the nighttime, high blood pressure. So this is one of the examples of one of the medical conditions that you were saying are associated with untreated sleep apnea, probably one of the most common. A male with high blood pressure, also who happens to be above the age of 50. I mean, now you're talking lots and lots of red flags. Every single one of these things are red flags, and I'm actually drawing them from what we call the Stop Bang questionnaire. This is a questionnaire that we as physicians use to assess somebody's probability of having sleep apnea, and it's based on 8 signs, symptoms, and risk factors, which include snoring, tiredness, witnessed irregular breathing by a bed partner. Very important to listen to your wife or girlfriend if they're telling you that you don't look good when you're breathing during sleep. You look like you're pausing and breathing, or you look like you stop breathing for a few seconds at a time and let out a gasp all of a sudden. High blood pressure, having a history of obesity, because this is, while not the only cause of sleep apnea, it is the most common risk factor for sleep apnea. And then also having a neck circumference greater than 17 inches in a male, 16 inches in a female. So these are all the different sort of risk factors and sort of features and other signs and symptoms that we see that really should alert somebody to thinking that sleep apnea is a possibility when they have these things.
No, that's so helpful. Thank you. I mean, that is so helpful and so important for people to know, especially given all of the serious medical issues that go with it. Now, you were mentioning some other potential conditions that cause people to stay awake at night, or I guess wake up again at night. Is restless legs involved in that? Because I know you talked about restless legs were for falling asleep. Is it also for staying asleep as well?
Really good question. So restless leg is something that the person purely experiences when they're awake. However, some people with restless legs, many people with restless legs, not all, some of them have what's called periodic limb movements of sleep. So periodic limb movements are essentially a mouthful for saying somebody who kicks a lot during sleep. But a lot of times, people who have restless leg while they're awake also have a lot of frequent limb movements while they're asleep. And some of them can be so vigorous or can be so forceful that they actually disrupt the sleep, or the movement actually awakens the person. And then once they awaken, they may not necessarily know what woke them up, that they kicked their legs so hard that it actually ended up waking them up. But they'll awaken very often, once again, with the restless leg symptoms, which happens again when you're awake. So it becomes this sort of thing where the person has the restless leg when they're awake, falls asleep, has the leg movements while they're asleep, wakes them up, and then wakes up again with restless leg and now has a hard time going back to sleep. So that's one pattern that we can see in a lot of pretty bad restless leg patients. But typically, once the person has fallen asleep, if they don't have periodic limb movements of sleep and they just have restless leg syndrome of wakefulness, then usually it doesn't cause a problem other than that. when they're asleep.
Got it. And on a high level for restless legs, what's the treatment for that? Is that like medication you take, or is that also cognitive behavioral therapy?
Very good question. So the treatment of restless leg, first of all, one of the most common and easily reversible and easily fixable causes of restless leg is a low iron storage in the body. There is a blood test that we check. It is called ferritin. Ferritin is not the same thing as checking a blood iron level. It is rather checking your body's iron storage level. For whatever reason, iron storage level, when it falls below a certain number, we say 75 typically for the ferritin level, very often we see symptoms of restless leg. And when we encounter that in somebody who has restless leg and we have their ferritin level and it's less than 75, all we do is usually start them on a regular oral iron tablet once a day, like the ones that you can buy over the counter at the pharmacy. And not only does it improve that iron storage level and improve that ferritin to above 75, but very often just the iron replacement alone will either totally fix or significantly improve the restless leg. However, if you have done that, then my approach, at least after that, is before you're considering medications for restless leg, really try to optimize the sleep itself. Because anything that can break the sleep, anything that can compromise the quality or quantity or duration of sleep that the person achieves can exacerbate a restless leg. We see restless leg and insomnia happen a lot, and the person's got really bad insomnia, really bad restless leg, and then once their insomnia starts improving, next thing you know, they're not getting as much restless leg. So anything stabilize or destabilizes the sleep can exacerbate this problem. So I try to really kind of do an inside out approach where something easy like the iron level, if I can fix it with a couple of months of just a regular iron tablet, and then optimizing the sleep itself, whether it's behavioral treatment or treating the sleep apnea, for example, which can also exacerbate a restless leg if untreated. And if I've really corrected all of these factors and done everything else, and we're left with just a really stubborn, resilient, bad restless leg, then I'll reach for the medications that we use. And typically there's one of two classes of medications that we use. There's what are called alpha-2 delta ligands, gabapentin being a very common one of those, and also our dopamine agonists, which are medications that actually have been used to treat restless leg for many, many years now and have a multitude of other indications, including Parkinson's disease.
Got it. No, that actually helps explain it quite a bit. So let's go to the last part of sleep. Now, we talked about falling asleep. We talked about sleep maintenance. What about the early awakening? And I'm not sure if I'm conflating things or not. I don't know if this is related to circadian rhythm problems or not, or because it's just a question of people sometimes shift their sleep patterns where they might be getting up too early or too late or whatnot. Can you speak to that a bit?
Absolutely. So early morning awakening insomnia, or as many people refer to as terminal insomnia. I don't like that term. That term sounds weird.
It's a little permanent, yes.
Yeah. But early morning awakening insomnia. So interesting things to keep in mind. So first of all, like I said, we have 4 stages of sleep: non-REM 1, 2, 3, and REM. Now, it normally takes us about 90 minutes to hit rapid eye movement sleep in the beginning of the night from the time we fall asleep. However, all throughout the nighttime, because our sleep runs in cycles, we hit REM sleep here and there, and then towards the second half of the night, we have a lot of concentrated REM sleep. So the majority of our rapid eye movement sleep is actually in those last few hours of the sleep period in the second half of the night. Now, one thing that has always been very interesting to me that I learned early when I was in my training, and one of my teachers, who was a wonderful, wonderful attending, who I've learned so much from, he basically told me, when you see early morning awakenings, think depression. And this is something that there is quite a lot of data on. Now, of course, I always tell people that even when I bring this up with my patients, I am not diagnosing you with depression based on the fact that you wake up early in the morning. That's right. However, in keeping in mind, in somebody who has this history, who has an uncontrolled mood disorder like depression, and they're presenting with early morning awakenings, this is a pattern that we see very, very, very commonly. In fact, other sleep-related changes that we see in the depressed population include an increased primary latency to REM onset, which is basically saying that rather than taking 90 minutes to initially hit that first cycle of REM, it takes them much longer than that. So then as a result, and then one other thing that we see is that they actually have more REM sleep as a percentage of total sleep time. So all in all, trying to say that there are a lot of changes with regard to sleep physiology and sleep architecture when it comes to mood. And it's very hard to break it down and isolate the exact reason, but simply put, a lot of the hormones that govern your mood on a daily basis, serotonin, norepinephrine, acetylcholine, different things. These are a lot of different neurohormones in the brain they work in a very special and unique way to sort of control the stability of REM sleep. See, REM sleep, it's kind of like if you looked at sleep in two different sections, REM and non-REM. Non-REM being, of course, those first three stages, and then REM being that last unique stage. REM has a different control center than non-REM does. Imagine two different control centers with guys sitting there with their mics and headphones and all that stuff, two different control centers. The control center for rapid eye movement sleep relies heavily on the same neurohormones that govern your mood. So the thought is, and of course, this is all hypothesis. There's no conclusive, data to really say that this is exactly what's going on. But when there is a disruption in the mood, when there is disturbance in the mood, well, those are the same exact hormones that govern REM sleep. And being that we get most of our REM sleep in those early morning hours, well, that may be part of the reason why we experience very many people experience early morning awakenings, specifically with depression.
That's so interesting. It's unbelievable how all these things tie together, and people think about mood as a completely separate issue that I'll just get over it and whatnot. And few people think about how deep this goes into the biochemical structure of your brain and how deeply entrenched it's all in. And to the point you made at the very beginning, how interconnected it all is, for sure. I just wanted to also touch about one thing that you had mentioned, just to follow up on that circadian rhythm disorder. Can you tell us about what that is and how you approach that?
Yeah. So circadian rhythm disorders are a subcategory of sleep disorders. There's really 6 of them that we kind of, most commonly we'll talk about. There's what's called delayed sleep-wake phase syndrome, which is, like I said, the typical teenager that gets into this habit of gradually delayed sleep times and gradually delayed awakening times to the point that they're sleeping from 6 p.m. to 3 p.m. Right. It's great. Once you graduate high school and go to college, now you can make all your classes for the evening and the nighttime. But if you need to start working a job and the boss says you got to be here at 8 a.m., well, then it can be a real problem for you. So that's definitely one of them. And then there's the opposite, advanced sleep-wake phase syndrome, which we see a lot in older adults. These are people who essentially are getting sleepy a lot earlier than desired. They're falling asleep in the early evening and then waking up in the early morning, 2, 3 o'clock in the morning. As with most circadian sleep disorders, including these two, if it doesn't bother the person, then you don't necessarily have a problem. Again, many people work the swing shift, and having a delayed sleep schedule works perfectly for them. So in these situations, no big deal. But if it does cause some kind of a distress or impairment of daily functioning, or they're not able to do their daily responsibilities or socialize, then of course you've got a problem. So that's advanced sleep-wake phase. And then there's what's called non-24 or free-running circadian sleep-wake disorder. This is something we see in a lot. We see mainly in blind individuals who don't have that sort of photoreceptor reception of bright light exposure. It's modulating the circadian rhythm. So as a result of lack of that input from sunlight or bright light, they have a very disrupted sleep-wake pattern as well, such that they end up developing this progressively delayed sleep time each and every day, and eventually it catches up and kind of makes a full circle. So that's that. And then we have extrinsic circadian rhythm sleep disorders, which include jet lag. It's a perfect example of a circadian sleep disorder where a person is traveling across time zones and experiences disruption to the sleep-wake cycle. They end up being alert when they should be asleep, and vice versa, and it can cause problems, especially if on a business trip. So that's jet lag. And then there's what's called shift work disorder, of course, which is when the person is a shift worker, whether it's a night shift or whatever the case may be. And as a result of the circadian dysregulation, they have difficulty either maintaining wakefulness during their shift, or they come home and they have a hard time falling asleep, and next thing you know, get insufficient sleep, which can impact the following night's shift, and so on and so forth. So that's kind of like a breakdown of sort of how the circadian rhythm sleep disorders go.
No, that's a great breakdown. And assuming that you can't get out of the situation, you can't get out of the shift work, you have to get there at 8 in the morning. And on a high level, I know that there are certain medications here and there that like, for instance, for blind people, I saw a commercial for one, but I'm assuming that on a high level, a lot of this is going to be addressed with cognitive behavioral therapy then, right? Because just like the example of the teenager, right, who's been, the reason why is that they're on screens till 3 in the morning. Is it the same fairly, like, is cognitive behavioral therapy a big treatment here for these type of circadian disorders?
It's a really good question. So It's more of the behavioral component of cognitive behavioral therapy. Absolutely. So the behavioral component, meaning optimizing the sleep hygiene and changing a couple of other behaviorals, making a couple of other behavioral adjustments. For example, what's called stimulus control. I won't get too much into that, but it is a behavioral treatment for insomnia, which is included in cognitive behavioral therapy for insomnia. It's something that can also be very, very helpful, specifically with these circadian rhythm disorders, because essentially it really comes down to, number one, if the person has a circadian rhythm disorder, it's important to know, okay, this is your current sleep pattern. This is your problem. What is your ideal sleep-wake pattern? What time would you like to get up to start your day? What time would you like to go to sleep at nighttime? And then sort of working it from there and determining how to sort of optimize the sleep and correct the problem, whether it is sometimes maintaining the same time of awakening every single day, which is part of stimulus control therapy, is effective enough to really get the person's clock reset and have them slowly sort of gradually advance their sleep schedule such that now they're back on track. But again, it really takes an individualized approach and really depends on the degree of the circadian disruption, whether it's a very delayed phase, a very advanced phase, or it's just very broken sleep. Again, it really takes, you're absolutely right. It takes a combination of really behavioral interventions and strategies to really improve these things.
Got it. So, we spent a good amount of time going through different scenarios, different types of sleep problems that can be self-created, externally created, internally created, et cetera. And there's a lot of them that are just sleep specific. But, and it's like when Arnold Schwarzenegger said in Kindergarten Cop, it is not a tumor, it is a headache. When do we worry about it's not just a sleep problem? What are the red flags that make somebody out there say, you know what, maybe my problem is a little bit more than insomnia, and maybe insomnia is a symptom and not the problem? Any thoughts about those red flags that you can share?
What a good question. It's really hard. It's really hard to say, because the red flags that we look at even as sleep specialists, let alone from the patient's perspective, but the red flags that we're looking at, again, are number one, non-specific. Number two, can vary from person to person. So in my opinion, I think the best thing to do is, if you're experiencing a sleep difficulty, whether it is disrupted nighttime sleep or daytime symptoms, rather than trying to just attribute them to the fact that you had a fight with your wife, or rather than just trying to say, okay, it's just some kind of pattern I've been in, and that's just this is how I sleep. Or, for example, I've always been the type that I can just fall asleep as soon as I sit down. Well, people with narcolepsy feel that way too. So it's important to kind of know these things, to notice that, or to take note, these things may not be normal, even though they may be normal to you. Having disrupted sleep at nighttime is not normal. Right. And being sleepy and fighting sleepiness during the daytime and needing caffeine, needing naps, needing to leave your office just to be able to go to the car for 20 minutes. It may just be insufficient sleep at nighttime, which is the most common cause of daytime sleepiness, of course, not getting enough sleep, but it may not be. It may be something else. Like I said, it might be narcolepsy. It might be sleep apnea. When a disease's symptoms are non-specific and sort of kind of perceived as normal as fatigue or sleepiness, it can be very hard to really define what that threshold is when you should see somebody, which is why I think that whether or not you've been experiencing these difficulties chronically, or you're going through a bad slump right now that's just not resolving on its own, like most typical transient sleep disturbances should and do. In those situations, just talk to your doctor. If there's any question whatsoever, see a sleep specialist. There's plenty of us around. We're located at all your major academic centers. There's plenty of us in the private sector as well. And having a consultation, just a one-time visit, can really shed light on a lot of these issues.
That's a perfect segue. So you know what, Dr. Kashani, you convinced me. I'm going to go see you as a sleep specialist, but I'm a guy like you. And guys are very nervous about going to see the doctor. That we prefer many things, including just getting some of our limbs removed from us while we're awake, to seeing a doctor, because we're very nervous. What is the doctor going to do to us? What are we going to expect? What's going to happen? I don't know. Usually the partner's pulling you in, by your hand. Please come see the doctor. If I decide, you know what, I agree. Enough is enough. There's only so much CBD oil I can take. I need to see a sleep specialist. What should I expect in coming for that consultation?
So, first of all, when you come in for a sleep consultation, what we're doing is essentially, first of all, trying to get an idea of obviously what the problem is, how long you've been experiencing it, just like any other medical problem, but really trying to me personally, my approach is I always like to start with the sleep schedule. really get a good idea of most nights of the week, because of course there's a lot of night to night variability when it comes to sleep for all of us, but really getting an idea of most nights of the week. What's your schedule? What's the bedtime range? I get to bed anywhere between 9 to 11. Once I get into bed, I'm asleep within X amount of minutes. Once I fall asleep, I have X number of awakenings most nights. Once I awaken in the middle of the night, I usually go right back to sleep, or I'm up for another 2 hours before I'm able to go to sleep. And my final time of awakening is 8 a.m., for example. Do you take naps? Do you awaken with headaches? Do you awaken with dry mouth? Both of these being symptoms or things that we very commonly see in people who have untreated sleep apnea. Do you awaken in the middle of the night, like I said, not only just gasping for air, but with palpitations, with your heart racing? Some of these things can signify something like sleep apnea. But even putting sleep apnea aside, again, do you have restless legs at nighttime? Does that affect your ability to fall asleep? Has your partner ever observed you exhibiting any strange movements, behaviors, or vocalizations during sleep to think whether or not there is concern for possible irregular breathing in the case of sleep apnea, or complex behaviors during sleep? Like I said, dream enactment behavior, people who have REM sleep behavior disorder who act out their dreams and end up hurting themselves because they punch their nightstand or punch their partner, or people who sleepwalk and end up falling down the stairs, or people who have other sorts of, or even just nightmares. Like I said, there's all kinds of, sort of nighttime sleep disturbances that we're screening for during these visits that really help to kind of clear up what the problem is. Because essentially, people are coming to see me as a sleep specialist for one of a few reasons. Either you have difficulty falling asleep at nighttime, you have difficulty staying asleep, or you wake up a lot, whether in the early morning or throughout the night, or you've got daytime symptoms, or somebody has witnessed something irregular or abnormal about your sleep. So these are really all the questions that I'm asking is geared towards each of these individual things. And from there, developing a plan, whether it requires doing an overnight sleep study to look for something physiologic, like I said, a movement disorder, a breathing disorder, or if it doesn't need a sleep study and it's something that's purely behavioral, like primary insomnia, in which case, like I said, behavioral therapy and CBT for insomnia is the most effective treatment.
Right. Right. So that doesn't sound so bad, so far. I mean, aside from a sleep study, which I assume they just monitor your sleep and put like leads on, any other tests or invasive procedures that I would have to go through if I went to a sleep specialist?
No. Very often, another thing that I'll do with patients is I'll give them a sleep diary. A sleep diary is essentially a 2-week sleep log, because sometimes, again, it can be hard to tell what the sleep problem is when there's so much variability from night to night, and certain symptoms or certain things don't necessarily add up perfectly in the mind of the clinician, as is the case with most medicine. So in those situations, very often I'll give the person a 2-week sleep log. I'll say, you know what, I'm not totally clear on what's going on right now, whether this is a behaviorally induced problem or there's something else that's kind of, affecting your ability to sleep. So why don't we do this sleep diary where you log your sleep for the next 1 to 2 weeks, bring it back to me, let's take a look at it, and this will clear things up. So that's another example of something that I'll do when I meet people in the first time.
Got it. And so, you had mentioned before cognitive behavioral therapy as a really great option, very comprehensive and you told us what it is for sure. Can you take a couple of minutes just to explain like how it actually works? Like what would be involved in terms of treating me with cognitive behavioral therapy?
Absolutely. So cognitive behavioral therapy for insomnia, when I say it to a lot of people, immediately they hear the words behavioral therapy and they think, oh boy, here comes a shrink. Somebody's going to sit there and talk to me about my problems and about my stress in life, and so on and so forth. And really, that's not what cognitive behavioral therapy for insomnia is like. Of course, if there is trauma in your history or stress in your life that pertains to the sleep difficulty, then sure, you can discuss it during those sessions. But what cognitive behavioral therapy for insomnia really is it's depending on where you do it. It's 4 to 8 sessions of, I liken it to personal training.
Okay.
When you're a personal trainer, what do? You pay the trainer, you show up to the gym, you do everything that trainer says for the next 60 minutes. They tell you, do 20 push-ups, get on the treadmill for 20 minutes, now do 10 squats, now do some deadlifts, lift up that 50-pound barbell, so on and so forth. They're basically giving you individual exercises, individual strategies that have evidence that work. And as long as you do, they're going to be tough. As long as you lift those weights, as long as you run run on the treadmill and you do everything they tell you, by the end of your 4 weeks, 6 weeks, 8 weeks, however long you're working with your personal trainer, you're going to get those results. You're going to get the buffness, you're going to get those muscles, you're going to start getting chiseled the more you adhere to exactly what your trainer is telling you. However, if you don't, or you want to kind of skip certain exercises, or you miss a couple of sessions, well, you're not going to get all the results that you want. And of course, like I said in the beginning, the first few days you work with a trainer after not working out for a long time, you're going to be sore. but that soreness goes away after a few days and you get into the habit. So how does that pertain to, or how does that relate to CBTI? Because really CBTI is you meeting with the person, whether it's me or another sleep behavioral specialist, who very often it's them who deliver CBTI. I will deliver it myself too. But essentially you'll see this person and they're giving you very specific evidence-based behavioral treatments and strategies that work, that improve insomnia, and they're difficult to adhere to because some of the things they have you do in CBTI are actually pretty tough. They do what's called, for example, sleep restriction, where they give you a very compressed bedtime window and you're not allowed to be in bed before or after it. And the bedtime window is compressed to actually somewhat kind of, in some ways, temporarily sleep starve you. But that's the idea. The idea is that we're temporarily sleep starving you while optimizing you and your association between you and your bed as the place of sleep and sleepiness, which is, again, the whole conditioning process that is broken during insomnia that we want to repair. Mm-hmm. And essentially, what you're doing is, like I said, doing these exercises on a weekly basis with this person. In the beginning, it's going to be very difficult, just like it is to lift weights after not working out for a long time. But as long as you adhere to it and you stick with everything that this person is instructing you to do for the course of these 4 to 8 week sessions, we don't have a more effective treatment for insomnia. One other really effective thing that they do in CBTI is, like I said, what's called stimulus control therapy. Stimulus control therapy revolves around 5 strict rules that all work towards one target goal, which is do not be in bed unless you're asleep. Mm-hmm. Sleep and sex are the only activities allowed in the bed. Everything else should be ideally outside of the bedroom. That's rule number 1 of stimulus control. Rule number 2 is go to bed when sleepy, no matter how late it is, because what is the alternative? Going to bed early when you're awake, and again, more frustration, more distress, more perpetual insomnia. Mm-hmm. Rule number 3, if unable to get out of bed, if unable to fall out of sleep, get out of bed after 20 minutes or so, because now the longer you lay, the more distress, the more frustration. Go do something boring, soothing, relaxing, devoid of an electronic device or any kind of stimulation or engagement, and return to bed when feeling more sleepy. Rule number 4, maintain the same time of awakening every single morning, no matter what, Monday through Sunday. And of course, my favorite response to that is, I'm already doing that. That doesn't fix my insomnia. I say, I know, but you're not doing that with all the other rules that I just named right now in conjunction, because these are not rules to be practiced one by one. These are things that work only when practiced together. And it can be pretty hard to maintain the same time of awakening every single morning if you go to bed as late as you can until when you fall asleep, and you get up and get out of bed 2 or 3 times in one night to do something relaxing and soothing and come back to bed. You might get a couple of nights in the beginning of CBTI practicing this technique where you only sleep 1 to 2 hours. Mm-hmm. That's the soreness, right?
Right.
But the soreness goes away after a few days when you start continuing to work out. The same way this does. The more you continue to practice these rules, the more improvement you have and the more you're getting sleep at nighttime. But again, it's difficult to do these things, which is why, like you said, many people do prefer the magic fix, the magic pill. But for the motivated person, this works more effectively than any pill.
Well, it sounds like, sure does. It sounds like kind of the old adage of there's no free lunch, right? And no pain, no gain. You have to dedicate yourself. If this is important to you, which it should be, because based on the beginning of this conversation, how important sleep is, you have to dedicate some energy to it. Otherwise, it's not just going to go away by popping a melatonin here and there. That's for sure. Last question for you with regards to just sleep in general and sleep specialists. You had mentioned that, there's sleep specialists in academic institutions, all across the country. But there's still a lot of them. And as a guy, if I'm looking through websites and trying to find somebody, a sleep specialist, or is there anything any advice in terms of how to find a sleep specialist? What should I look for? What questions can I ask in terms of finding the right sleep specialist for me?
It's a good question. I think ultimately that what we do in our approach as sleep medicine physicians to treating all of these problems, it's not very different. I think that one thing to keep in mind is, number 1, many sleep medicine physicians practice behavioral sleep medicine, but not all of them do. And I think that for behavioral sleep problems, specifically insomnia, which is the most common sleep disorder in the world, if you are going to pursue behavioral treatment, which is, like I said, the most effective treatment that we have at CBTI, if you can find a sleep specialist who delivers both regular clinical sleep medicine practices regular clinical sleep medicine and delivers behavioral sleep medicine treatments and modalities, well, that's kind of a more sort of all in one place instead of seeing one person and then getting a diagnosis of insomnia and then referring you to another person to do the behavioral treatment. Not that there's anything wrong with doing it that way either. But that's one thing that at least I would think from a standpoint of a patient, if I could get all my sleep care and sleep needs met by one person in one place, that would be a personal preference of my own. So that's one thing I think that people can look out for, is trying to determine and trying to see what's available to them in terms of both clinical sleep medicine specialists as well as behavioral sleep medicine specialists. It's hard to find a person that can that practices both. It's not as common, but they're out there. And if not, like I said, no worries. You can still see a different person for the behavioral sleep issue. But ultimately, the way that we approach all of these things is pretty uniform and pretty much, adherent to the standards of care.
No, that's actually great advice. You definitely, if you can, you definitely want to work with one person, not, you're nervous enough going to one, much less too many, right? So listen, thank you so much. I mean, this has been extremely helpful. I'm going to leave with a non-sleep related question that I asked all our specialists. You've had an interesting journey from entertainment to medicine, and specifically in sleep, and you're obviously a very successful person. What is your secret to your success? If you had to give the guys out there one piece of advice to live their best life, what would it be?
Gosh,
that is a quick question for you.
I would say that working really, really hard is the best answer that I could give you to that. Because personally, when I look at my own journey, like you said, coming from a film background and working in the film industry, and then producing my own films, and then making the transition to medicine was really, really difficult. But and there were periods of time, even in medical school, where I said, you know what, I think this was the wrong choice. This is not for me. I'm not supposed to be studying these things. My brain can't even comprehend some of these things that I'm trying to read. But what got me through every single one of those episodes, and what got me to where I am, is just ignoring that and working really hard right through it, and just fighting right through, and just keeping that go mentality, just like a lot of other people out there. There's nothing special or unique about me, but essentially I find that there's nothing that we can't overcome with just working our asses off, excuse my language.
That strikes home for sure. Perseverance is the key. If you set your mind to it, most of the time you can get there with just the grit and the hard work. And great place to leave off. Dr. Kashani, thank you so much for joining us. You provided us a wealth of information about all kinds of issues with sleep that I know the guys out there are appreciating. For everyone listening, thank you for joining us. Remember our philosophy here at Better Man's Clinic, that your best life is a journey and not a destination, and use every day to get just a little bit better. If you enjoyed this podcast, please rate it highly for us on whether you're on YouTube or Apple Podcasts or Spotify or wherever you're joining us from. And we look forward to talking to you guys next time. Take care.